Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
All right, let's jump right in. Today, we're doing a deep dive into pulmonary embolism. And we're going to really zero in on the diagnostics.
That's good.
We've got some great research lined up here.
Yeah, definitely important stuff for any healthcare provider. You know, when you're thinking PE could be in the table.
Absolutely. We're talking D-dimer, EKG, those radiological signs, all those imaging techniques. We're covering the whole spectrum today.
Should be good.
So let's just kick things off with D-dimer.
Okay.
I was actually looking at this PARTE Consortium Handbook of Pulmonary Embolism.
Yeah.
And one thing that really popped out at me was this discussion of age-adjusted D-dimer thresholds.
Uh-huh.
It's really a reminder that we can't just be looking at the number itself, you know, especially when we're dealing with older patients.
Oh, for sure. Definitely older patients can have those naturally elevated levels just from age-related changes, you know, in coagulation and fibrinolysis and all that.
So what's the takeaway here? Do we need to order like a separate age-adjusted D-dimer test, or is it more about how we're interpreting the results?
I'd say it's more about interpretation.
Cool.
Some labs actually will give you those age-adjusted cutoffs, which can be really helpful.
Right.
You know, you might see a D-dimer of, say, 800 in like a 70-year-old patient.
Okay.
And if you're just going by that standard cutoff, you might think, oh, that's fine.
Yeah.
But then you look at the age-adjusted interpretation and you realize, whoa, this is actually pretty high for their age.
Gotcha. So that could really make a difference.
Oh, yeah. Definitely a crucial point.
Let's switch gears a little bit and talk about EKG.
All right.
The research really emphasizes that it's not like our primary tool for diagnosing PE,
Right.
but there are some findings that should kind of set off those alarm bells in our heads.
Definitely.
So we're not looking for a definitive diagnosis right there on the EKG.
Right. It's more about those clues that suggest right heart strain.
Okay, right heart strain because of that obstruction of blood flow in the pulmonary arteries. So walk us through it. What are some of those EKG findings that would make us think, could this be a PE?
Well, you know, if you see a new right bundle branch block, especially if it seems to have come on suddenly, that's always a red flag.
Yeah.
Then there's that classic S1Q3T3 pattern.
Right.
Not as common, but when you see it, pretty specific for right heart strain.
Okay.
And even just like subtle T-wave inversions in those right precordial leads.
Like V1 to V3.
Yeah, those could be a sign that something's up.
So we're really looking for anything that tells us that right heart is working harder than it should be.
Basically, yeah.
All right, let's move on to radiology.
Okay.
I mean, with all the fancy imaging we have these days.
It's pretty amazing.
It is, but those classic radiological signs, they haven't gone out of style, have they?
They really haven't. No, Hampton's hump and Westermarck sign might not be super common, but when you see them on that chest x-ray, it can be really helpful.
Especially when other tests aren't giving us clear answers.
Exactly.
So what are we actually looking for with these signs?
Okay, so Hampton's hump, it's a wedge-shaped kind of opacity,
Okay.
usually at the edge of the lung near that costophrenic angle.
Gotcha.
It basically shows us there's a pulmonary infarct.
From the PE.
Right. And Westermarck's sign, that's an area where you see decreased pulmonary vascularity.
Okay.
It kind of shows you where that clot is actually blocking the blood flow.
So Hampton's hump shows us the damage, and Westermarck's sign shows us the blockage itself.
Yeah, that's a good way to put it.
It's fascinating how these signs they discovered, you know, so long ago are still relevant.
It really is. Those early radiologists were pretty sharp.
So let's talk about the modern imaging techniques.
Right.
CTPA, VQ scans, even ultrasound. The research really breaks down the strengths and weaknesses of each.
We've got a lot of options now.
We do. So CTPA, or computed tomographic pulmonary angiography, that's generally considered the gold standard, right?
Yeah, pretty much. It's highly sensitive, highly specific for detecting PE.
And we can see right heart strain and other potential complications. So why wouldn't we just do a CTPA on everyone with suspected PE?
Well, there are a few things to consider.
Okay.
There's the radiation exposure, which we always want to keep in mind.
Especially for younger patients.
Right, or people who might need repeated scans.
Makes sense.
And then some people just can't have that intravenous contrast.
Allergies, kidney problems.
Exactly.
So what are our options when CTPA isn't a good choice?
Well, the research talks about VQ scans.
Okay, VQ scans.
Ventilation perfusion scans. They're a good alternative.
So how do those work?
You have the patient inhale a radioactive gas,
Okay.
and then we inject a radioactive tracer, and that lets us see how air and blood are moving through the lungs.
And what are we looking for in the results?
We're looking for mismatches between the ventilation and the perfusion.
Okay.
So if you see an area that's got good ventilation but the perfusion is poor, that suggests there's a blockage.
Which could be from a PE.
Right.
So VQ scans, they're not directly showing us the PE,
Not directly, no.
but they're giving us those clues, like impaired blood flow.
Exactly.
What about ultrasound? I thought it was interesting that they mentioned that as a tool for PE.
Yeah, ultrasound's not usually the first thing we think of.
Right.
But it can actually be pretty useful in certain situations.
How so?
Well, we can use it to look at right heart strain.
Like we do with echocardiography.
Exactly. We can see if the right ventricle is dilated or if it's not functioning well.
So we're basically seeing the effects of the PE on the heart in real time.
Pretty much, yeah.
And that can help us figure out how severe the PE is.
And guide our treatment decisions, absolutely.
I've even heard you can sometimes see the thrombi in the pulmonary arteries themselves with ultrasound.
Yeah, you can. It can be tricky, though. It's more technically
It
challenging.
really is amazing how versatile ultrasound is.
Definitely a valuable tool.
It's like having a window into the body. We can see so much.
It's all about having a good understanding of all these tools. That's the key.
Right. They each give us a different piece of the puzzle.
Exactly. And when we put it all together, we get the full picture.
Okay, I want to touch on something we haven't talked about yet, clot burden.
Clot burden.
Yeah, the source material mentions it as a factor in how severe the PE is. It's talking about the size and extent of that blood clot in the pulmonary arteries.
Right.
So bigger clot burden generally means a more severe PE.
Yeah. Generally, yes, but it's not always that simple.
What do you mean?
Well, you have to consider other things, too, like what other health problems the patient has and where exactly that clot is located.
So it's not just about the size of the clot, it's about the whole clinical context.
Exactly. Every piece of information has to be interpreted in light of that patient's individual situation.
That's really the art of medicine, isn't it?
It really is. We have all these tools and data, but it's our judgment that guides us.
And that's why these deep dives are so important.
Absolutely.
By really understanding all the details of each tool and finding
We become better clinicians.
more confident, more discerning.
Couldn't agree more. We have to keep learning and growing, especially with a condition like PE.
It can be life-threatening.
Exactly.
So we've covered a lot of ground here: D-dimer interpretation, EKG findings, those classic radiological signs, and all the different imaging modalities.
And we talked about clot burden and how important that overall clinical context is.
This has been a really helpful discussion so far.
Glad to hear it.
I feel much better equipped to really approach PE diagnosis with all these nuances in mind.
That's great. And remember, this is just the start. There's always more to learn, and we got to stay up to date. This field is constantly evolving.
Absolutely. So to our listeners out there,
Yeah.
what part of PE diagnosis has really caught your attention today?
What are you going to be thinking about more in your own practice?
Keep those questions in mind as you continue to build your expertise in this really important area of patient care.
It's crucial.
It is. You know, it's interesting you mentioned staying up to date because while we talk about CTPA being the gold standard, there's been a lot of discussion about VQ scans lately,
Yeah, definitely.
especially with all the concern about radiation exposure.
Yeah, for sure. We're all more aware of that these days,
Right.
especially with younger patients.
And anyone who might need multiple scans.
Exactly.
So VQ scans, they offer a lower radiation dose,
They do.
but we still get good information about lung perfusion.
Right.
So do you think there are times when we should choose a VQ scan over CTPA, even when contrast isn't a problem?
It's a good question.
Yeah.
It really depends.
Okay.
In some cases, a VQ scan can actually be more sensitive.
Really?
Yeah, for those smaller emboli, the ones way out in the periphery.
Interesting.
Because VQ is looking directly at perfusion,
Okay.
whereas CTPA is looking for filling defects,
Right.
which can be hard to see in those tiny vessels.
So it's not always so clear-cut.
It's not.
We have to weigh the pros and cons
Absolutely.
for each patient.
It all comes down to clinical judgment.
Right, thinking about their age, their other health issues, their history with radiation. How high is our suspicion for PE?
Exactly. It's a lot to consider.
Diagnosis of PEN. CTPA is the first-line imaging modality for the diagnosis of PE. It has surpassed VQ scanning and conventional pulmonary angiography as the gold standard in all diagnostic algorithms for PE. CTPA allows for adequate visualization of the pulmonary arteries down to the subsegmental level. CTPA is effective in rapidly diagnosing PE with a sensitivity of 83% and a specificity of 96%. Risk and severity assessment. CTPA can assess the severity of PE by quantifying the obstruction of the pulmonary vascular bed or by measuring indirect markers of right ventricular dysfunction, RVD. Parameters include pulmonary, artery obstruction indices, pulmonary artery, PA diameter, and pulmonary artery, aorta ratio, right ventricle, left ventricle, RV-LV ratio. A value, 0.9, is considered an independent predictor of adverse in-hospital outcomes. An RV-LV ratio is associated with a 2.5-fold higher risk of all-cause mortality and a 5-fold higher risk of PE-related mortality. Bowing of the interventricular septum and inferior vena cava reflux. CTPA is also used for risk stratification, both short-term and long-term. CTPA parameters can be used to identify high-risk patients, including the presence of thrombi in the main pulmonary artery trunk. CTPA can detect signs of pre-existing pulmonary hypertension. CTPA can also help assess thrombus volume and thrombus burden. Additional information provided by CTPA. Assess the right ventricle. CTPA can detect RV enlargement as an indicator of dysfunction. Rule out differential diagnoses. CTPA is useful in ruling out other causes of symptoms, such as pneumonia or pneumothorax. Identify artifacts. It is important to identify artifacts such as mucus plugs, pseudo-defects of hilar lymph nodes, motion and slow flow artifacts that can lead to misinterpretations.
Thanks so much for joining us today on the Emergency Room podcast. Please smash that like button, it helps us reach more colleagues and keep the educational content coming. Don't forget to share this video with your fellow healthcare professionals. And if you're not already part of our community, please subscribe to the channel and hit the bell notification so you never miss out on our next cutting-edge discussion. We're dedicated to providing the most up-to-date, evidence-based information to keep you at the forefront of emergency medicine and critical care.